Welcome. Thank you for joining our webinar, Automated Maternal Early Warning Systems Providing Equitable Care at the Bedside. Just a little disclaimer, this presentation includes information from sources designated on the slides. If you'd like a resource list, we can provide that upon request. A little bit about the host, PeriGen. So PeriGen has provided innovative software solutions for over 20 years with a mission of protecting all moms and babies. PeriWatch Vigilance is an automated early warning system that works with any existing electronic fetal monitoring software to quickly and consistently identify patients who may be developing a potentially worsening condition. This artificial intelligence software solution can be used to help standardize clinical interpretation within your unit and across any healthcare enterprise. Used as an early warning system for mom and baby, it can help clinicians and providers intervene sooner, potentially improving outcomes for moms and babies. So our presenter today is Dr. Alana McGolrick, Chief Nursing Officer at PeriGen. With significant perinatal experience, Dr. McGolrick leads PeriGen's efforts to expand and enhance clinical education, customer outcomes, reporting, and publishing. Our co-presenter today is Karen Kallega, who we call KK, a clinical engagement executive. Karen is a clinical subject matter expert for PeriGen's obstetrical software. Her expertise in obstetric practices, regulations, and hospital operations improves prospective clients' engagement, adoption, and implementation. And now I'll hand this over to our speaker, Dr. Alana McGolrick.
Thank you, Lexi. Welcome, everyone, and thank you for joining today's discussion. The PowerPoint will be made available at the end of today's presentation. On the slide is the objectives that will guide our learning discussion today. I hope that you keep those in mind as we move through today's curriculum and refer back to them to ensure that we've met our intended goal. For the remainder of today's discussion, I ask that you keep the word equitable and its definition at the forefront of your mind. Consider its application to nursing practice. How do we provide equitable patient care? Can we always be fair and impartial during each patient interaction? Perhaps at the conclusion of this presentation, you may have some ideas on how to address this on your unit. In order to understand the pathway to equitable care strategies, let's consider where we are and start with the problem, our rising maternal morbidity and mortality rates. According to the CDC's most recent data, the United States is experiencing a rise in the pregnancy-related mortality rate, which in 2016 was recorded at 16.9 deaths per 100,000 live births. We are currently failing to meet the Healthy People 2030 maternal mortality rate, which is set at 15.7. Continuing to remain idle and hoping that the situation will change leaves our patients at risk of severe injury or death. The CDC also reported that current leading causes of pregnancy-related death in the United States include cardiovascular disease, infection, and maternal hemorrhage. Obstetric safety strategies must be multidisciplinary and supported by the healthcare organization. It is important that the interventions implemented are impactful and are built upon a solid foundation of compliance. So let's look at the background of M&M rates. According to McDormand et al. In 2016, 40 to 50% of maternal deaths were potentially preventable, and that despite access to the world's leading healthcare, the United States has not made a significant impact on obstetric patient safety. The research has shown that most preventable maternal deaths were preceded by changes in vital signs. Unfortunately, clinicians' failure to appreciate the patient's worsening condition has been a major contributor to the rising maternal morbidity and mortality rates. The near doubling of the national maternal severe morbidity rate has led government leaders to demand immediate action. Although our patient M&M rates have the spotlight, solutions have been left up to individual healthcare organizations, state collaboratives, and professional organizations to address. This has led to multiple solution proposals, but no standardized approach with a template that everyone can implement. Significant contributing factors have led to the rising national maternal M&M rate, including the changing medical complexity of the obstetric patient. Our patients are diagnosed with complex comorbidities associated with pregnancy, thus negatively impacting maternal fetal well-being. The pathophysiology of leading comorbidities, diabetes, hypertension, obesity, and cardiac disease are greatly unappreciated. We've been unable to agree on the best approach to managing the maternal patient. This includes implementing simple oxytocin checklists to more complex disease processes such as preeclampsia. Limited research exists related to maternal early warning systems despite success with the adult non-pregnant patient population. Clinical experts in maternal fetal medicine have been unable to reach consensus on physiological parameter thresholds. This has led to a variety of treatment protocols that vary across the country. How can we ensure that equitable care is provided to all patients if we continue to use different approaches? In many cases of unexpected outcomes, early signs of impending maternal collapse went underappreciated. We have been lulled into complacency by the fact that these are rare events in perinatal, and our patients have been historically healthy. This complacency contributes to the culture of normalized deviance, impacting our objectivity at the bedside. Addressing these two factors are the second step towards providing fair patient care. The landmark publication, To Err is Human, by the Institute of Medicine in 1999 was met with surprise by most of the healthcare community. Concerning findings by the book's authors painted a grim picture regarding unsafe healthcare practices causing medical errors to be the third leading cause of death in the United States. This led to a direct push to analyze the cause of these errors and to put into place safety barriers to protect patients from human error. Most importantly, the book did not place blame on the clinician at the bedside, but at the systems and processes in place leading to the unexpected event. This shifted the focus from the human, because we're not infallible, to the processes established by the organization. This redirection made it a priority of the organization and called upon leadership to support necessary changes to standardize care and protect our patients. To quote the iconic film star, Audrey Hepburn, "I don't believe in collective guilt, but I do believe in collective responsibility." I believe that this quote encapsulates the epitome of causative factors in relation to unexpected events. We are, after all, human and imperfect. We make mistakes, but what we do to prevent them is what makes us better as human beings and clinicians. The biggest mistake we can make as clinicians is to lower our standards and begin accepting shortcuts or deviations from approved procedures as the new normal. This is known as the phenomenon as normalization of deviance. Diane Vaughan first used this phrase in her book documenting the Challenger disaster in 1986. Briefly, the engineers responsible for testing the Challenger continued to push the limits of a specific O-ring design, allowing for the acceptable range of damage to continue to widen. While launch after launch pushed the limits further out, the original abnormal range was accepted as the norm, leading to the disaster. Can we look at this event and apply the concept of normalizing deviance to our own units? Consider that the pathway to normalize deviance does not happen overnight, but becomes ingrained into our culture through repetition and rationalization, as our behavior encourages complacency. I ask that you consider your current place of work while we discuss the following points. Variation in practice that deviated from the hospital policy and procedure is common as we experience emergent and urgent situations requiring speed while performing patient care and fast decision-making. This can lead to shortcuts being taken, and unfortunately, peers observe these deviations and begin to incorporate them into their own practice, but not during emergent or urgent situations. This enforces the bad behavior, and then it is replicated by others, subtly changing culture and, of course, impacting patient safety. This persistent risk-taking behavior leads to the opportunity for harm to occur, and while the clinician underappreciates the domino effect of these shortcuts, we end up with unexpected outcomes. Category 2 Category 2 is a great case example of how normalized deviance is practiced on our unit. Category 2, not being category 1 or 3, but that lovely gray zone that causes the most angst during fetal assessment. Unfortunately, we sit and we stare at it, maybe hoping it will improve. Time slowly ticks by, and without warning, it's been 2 hours and recurrent variables remain present. The watch and wait cycle has been perpetuated as a common approach to category 2 tracings. How comfortable are you with this pattern? I am sure you've labored a patient whose fetus was unaffected by a lengthy exposure to recurrent interruptions in cord circulation. That one experience, when the nursery nurse awarded a 9-9 APGAR and the baby came out just fine, has clouded any other experience with recurrent variable decelerations over a lengthy time. That baby may have been fine, but because we've become compliant with accepting that and the watch and wait approach is still in place, we leave our patients at risk. This is the normalization of deviance and our inability to remain objective because of preconceived expectations. A quick Google search reveals multiple malpractice cases with big dollars associated with category 2 unexpected outcomes. Case summaries indicate that doctors and nurses missed the signs that the baby was in trouble, thus requiring the use of artificial intelligence-powered early warning systems to maintain objectivity. So that leads us into the next part of the discussion, which is on maternal patient safety. If we have a culture that is perpetuating normalized deviance, we need to evaluate its impact on maternal patient safety. The Joint Commission identified several threats to maternal patient safety via collated sentinel event review data. 2 separate pathways can be distinguished to address solutions to maternal patient safety: people and process. Focusing on implementation of checklists and stopgaps addresses the process issues through multiple studies, but recently, literature supporting reduction strategies be focused in improving the areas of communication, culture, staff competency, and the environment. So how can we as individuals make a difference? Since most quality improvement solutions are multidimensional, we need to focus our approach on choosing strategies that assist with providing fair and impartial care. We have already discussed the first, avoiding normalized deviance. Let's move to the next one, remaining objective at the bedside. So the definition of subjectivity is based on or influenced by personal feelings, tastes, or opinions. The opposite being objectivity, which is our lack of favoritism from one side or another, and we are free from bias. So I thought that this slide really displayed where our patient sits, right in the middle of these definitions of subjectivity and objectivity when we are performing our assessments and care at the bedside. If we're completely honest, most of the time we can remain impartial while providing care. But there are times when our own personal experiences may impact decision-making or challenge our plan of care because of previous patient experiences. So that brings us to the opportunity to perform some self-reflection. So we're going to take a moment to consider these questions, and certainly I'd like you to consider them longer as you move through perhaps your day as you're taking care of your patients. The first, how do we provide equitable care if we naturally have personal feelings, tastes, and opinions? It's not as easy as it looks. Unfortunately, we put our feelings, we come with a set of feelings and personal tastes and experiences, and we certainly have our own opinions, but we have to move towards a center where we can put those feelings aside and provide care the same way for everyone. How can we address subjectivity at the bedside? We have to take one opportunity, one personal taste, one feeling, one opinion, and move that to an objective personal stance so that you do not allow the influence from your own personal set of feelings to come to the bedside. We need to avoid taking shortcuts and ensure that we provide the expected prescribed care every single time. Can personal preconceptions about others affect our decision making? In my opinion, yes. But we must remain acutely aware of our own personal preconceptions and not allow them to cloud our judgment in the healthcare setting. This seems simple enough. This is not always as easy as it sounds. So how can we support our own personal objectivity at the bedside? And I think the only takeaway from this part of the presentation is that you consider looking at just one aspect of your personal subjectivity that you can manage day to day. And I think then we'll see a difference. But here's some examples. One is controlling assumptions of the situation. We have to assume that every patient has their own individualized plan of care and that every patient situation will be different than the next. Some care aspects may be similar to others, but know that not all patients are going to follow the same template. Certainly in labor and delivery, we know this is not the case. They're all different. We need to rely on our clinical judgment and use that as a holistic approach to assessing the entire clinical picture. That will help remove any subjectivity that you may have based on any personal or previous experiences with similar types of patients. Avoid behavior that supports normalizing deviance. Be that role model. Don't take shortcuts. Or if you do take a shortcut, identify it and explain why you had to take that shortcut. Acknowledging that normalization of deviance allows others to see that you were aware and taking accountability for not following the established safety practices. Manage personal cognitive dissonance and practice self-reflection to address any personal conflicting beliefs. Nursing is an empathetic profession. It is our duty to respond with compassion. Remember why you came into nursing in the first place and why you chose labor and delivery. Finally, utilize technology to alleviate subjectivity at the bedside. Tools have been developed to support decision-making and justify interventions and plan of care through objective data submission. This quote resonated with me quite a bit, and perhaps more so because this is, we're during a pandemic, and I live in California, so I'm still in somewhat of a lockdown compared to the rest of the United States. And being a nurse, I just thought that this bared some reminding. Objectivity is seeing all the issues and feelings and contributing without bias. Objectivity is the absence of bias, not the absence of empathy. We are busy trying to complete tasks, protect ourselves and our patients from contracting this disease, but it is more important now than ever that we take the time to listen, deep breathe, and respond with empathy. So the last step to success that we've identified is using early warning systems. So we as perinatal professionals must begin to think outside the box and be creative with our approach to safe maternal care. This takes a coordinated effort to be transformational and lead, or in some cases catch up with, other healthcare delivery models that rely on objective data through technology and the art of practice. By doing so, we can be successful in designing quality care for the maternal fetal dyad in innovative ways. We will now discuss the need, which is our final step, for an automated maternal fetal early warning system. So early warning systems are tools used by clinicians to identify patients in a worsening condition. These tools vary in design, assigning scores to patient physiological parameters. Any breach in those established thresholds notify the clinician that the patient is worsening. Early warning systems improve the timely recognition and promote early intervention to reduce unexpected outcomes. These tools rely upon objective data, thus reducing the influence of subjectivity, and enhance clinical assessment and decision-making. So let's discuss the brief history of maternal early warning systems. The literature shows that early warning systems have been utilized in the non-pregnant patient population for over 2 decades. These studies have data that show early warning systems can alert the bedside clinician that a patient is developing a worsening condition prior to deterioration. The alert criteria based on vital signs are designed to prompt clinical actions in a timely manner. Setting assessment times with specific routine and repeated intervals, or whenever a trigger is found to have been breached, allow for a judicious approach to patient care. Finally, in 2014, Meyer et al. Reached consensus on physiological parameters for the perinatal patient. These parameters provided the first steps towards standardizing the content of maternal early warning system. PeriGen, with those parameters, built Vigilance, the only automated maternal early warning system, to assist clinicians with appreciation of patients' worsening condition and to address the rising maternal morbidity and mortality rates. The evolution of the paper pencil tool to a completely automated maternal fetal early warning system empowers decision-making and offers a superhero-like set of senses to care for the perinatal patient. So here are some examples of early warning systems that you may be familiar with today. So we're just going to discuss briefly what the benefits of an automated early warning system are. Literature on maternal death has shown that delaying care and timely interventions play a significant role in contributing to the unexpected outcomes. The literature also supports the need for early warning systems, promoting a proactive response to a patient deterioration instead of a reactive response. Early warning systems are simply calculators, prioritizing clinically relevant patient information for the clinician. Automated early warning systems for the maternal fetal dyad provide an objective identification of at-risk patients and promotes equitable delivery of care. It fosters collaboration and communication throughout all stages of perinatal. The automated early warning system supports provider decision-making through utilization of artificial intelligence. So now I'd like to hand the presentation over to KK to discuss our automated early warning system for the maternal fetal dyad, Vigilance.
Great. Thank you so much, Alana, and thanks so much for joining us today. Alana, once again, you deliver a terrific webinar with current, timely, quality content. It's fantastic. Alana outlined the benefits of an automated early warning system for mom and baby, and I'm here to give you an overview of the Vigilance early warning system. First things I'd like to let you know is that it's an early warning system, not a documentation system. It aggregates data from your fetal monitor and your EMR, and it analyzes that data and gives it back to you with actionable information. It is not, you do not need to rip and replace the systems you already have in place. It will overlay those systems. It is a software system. It's a quality improvement tool, so it doesn't send information back to the permanent medical record. And lastly, the goal, as Alana outlined, is to provide caregivers with timely notifications of potentially worsening conditions so you can assess that patient, intervene as necessary, and potentially avoid a delay in care. So here you can see the Vigilance multi-patient view. Over here on the left is patient information that we map in from your ADT data. These columns represent the OB information that is mapped in from your EMR or your surveillance system. So you have your gestational age, your GMPs, your dilatation and facetization, and your status of your membranes. Again, that's all going to map in when you update the information where you already have documented it. We'll map it into here so you can see it here also. These three columns are your early warning columns. You can see they have coloration going on. That is your visual notification that a parameter of some sort has been breached, that you have a patient that has exceeded a parameter of some sort and needs attention. So this column right here is curve. Excuse me, it provides an objective assessment of the patient's progress through labor. If they were to slow or they are to fall off the curve, then you would get this orange notification. This is vital signs. We are going to set the limitation parameters here to whatever you already have in place at your facility. Many facilities are already on a maternal early warning journey of some sort and have parameters for their vital signs, for highs, lows. We're going to mimic them in this system so that you will get that visual notification. And this is your column for cues. Cues is early warning for for potentially patterns that are developing in the fetal tracing. You do get an orange notification if there are concerning tracings that are developing. Here you do have a comment column, so you could put something here that is a trigger to let you know a little bit more about the patient. If you had this patient right here, you were concerned because you have 2 triggers that have been breached. All I'd have to do is one click and I get to this single patient view. You have a lot of information aggregated in one place for you in this single patient view. This upper area is pattern recognition. You see the icons up here. All I need to do is hover and it gives me more information about that finding. I'm on a variable right now. Variables are colorized yellow. If I was on an acceleration, which is a good, happy finding, it would be green. And then those findings that have more implications for fetal acid-base status are going to be brown. So the darker the color, the more concerning we get. So the brown ones are late, prolongs, and variables that break the 60 by 60 rule. If I was to hover over contractions, I'm going to get more information about the duration of that contraction. And it's always a big satisfier to know that if you had an IUPC in place, it would automatically calculate your MVUs for you. This pattern recognition that you're seeing here has been validated by the NIH. Their maternal fetal experts had substantial agreement with the pattern recognition in the PeriGen algorithm tool. That algorithm is available right here. You can see it. I'm going to bring that up for you. So this is the algorithm that is running in the background 24/7, powered by AI. It is on average over the last 30 minutes. If you have a mean baseline variability less than 6 beats per minute and no 15 by 15 A cells, you're going to turn orange. So in this situation, you have absent or minimal variability, no A cells for 30 minutes, you'll turn orange. You know, Alana laid out a lot of information about early warning. The idea is give you information before the deterioration really starts so that you have that opportunity to go in there, assess, intervene, and prevent the worsening outcome. So this one is not hair on fire at all. This one is the baby sleeping? Is the baby sick? I don't know. Let's go in and assess. Early warning. Late decelerations greater than to equal to 3 in 30 minutes, you're going to turn orange. If you have greater than equal to 2 decelerations that break that 60 by 60 rule, you're going to turn orange. If you have these combinations of decelerations, you're going to turn orange. And then this one is contraction count greater than or equal to 16, you're going to turn orange. That 16 sounds funny. We know our NICH definitions inside and out. If you take that 10-minute definition, extrapolate to 30, that is a state of uterine tachysystole. This may look familiar to many of you. It is an oxytocin checklist that is evidence-based and used heavily in the industry. So that's what's running in the background 24/7 for that extra set of eyes, that extra set of safety. Over here, you have a summary of your tracing, what's been going on in the last 30 minutes. And again, you see an orange icon. So we really try to put that orange in many places to draw your attention to the fact that this patient needs to be assessed. So here again, it's saying the reason you're breaching a parameter is contractions, and you can clearly see there's too many of those. This panel right here is your trend view. You can see either a 4-hour trend or a 12-hour trend. With one click, I can get to that 12-hour trend. So I can see 12 hours compressed of tracing on one. And it gives you another visual of that colorization that I was talking about. So you see this patient was doing quite well, sea of green. And then we start to get into a little bit of purple. Okay, but you see you also have areas pointed out in orange here where you are breaching parameters and you need some sort of intervention. This is a slider window, so all I need to do is move this and you see that the tracing in the upper panel is then displayed largely wherever I am over this tracing. So I can quickly scroll through hours and hours of tracing using this slider panel. This example right here, you see I have 12 on the screen, but I have a total of 20 hours. If I keep going, I can see the entire time that she's been on the monitor that easily, that quickly. I can scroll through hours and hours without having to unravel that paper like we used to have to do. So it's lovely to have that trend view to see those subtle changes over time, and they will get called out here if you have concerning trends. This is your vital signs window. We have trended vital signs. Again, whenever you have parameters that are outliers, you're going to get that orange icon. You see we have high pressure going on here. The other thing is all I need to do is hover over the element and it'll show me what those findings were at that time. And then lastly, you have your labor curve in this panel on the bottom. This is a modern labor curve. It is, it's not Friedman, it is not Zhang. We use many more parameters in our modern labor curve. So we use things like gestational age, what's her gravida and parity, are they a VBAC or not? Do they or do they not have an epidural? And then because we're in computer world, we can also use how often is she contracting in that equation. And then what we do is then we put those parameters together and compare your patient against a like population to then determine their percentage on the curve. So again, objective assessment of their progression through labor. Here is your zone of normal, this orange colorized, and then you have your 50 percentile line right here. And your black line is her curve and her checks. All I have to do is hover again over that element to see what the check was at that time. Importantly, to the right, I have the percentage of where they lie on the curve. And then here, I have a message. So this patient's dilatation is within expected range. Yay. Next level of messaging would be it's prolonged or they have not had dilatation for a certain amount of hours. That would turn orange. Again, the idea is early warning. We don't want to turn orange when she's off the curve. We want to turn orange when it's slow. You have an opportunity to intervene, do what you can to support this labor, promote that vaginal birth. So that is Vigilance in a nutshell. I thank you again for your time, and I'm going to turn it back over to Lexi.
Thank you all very much. KK, thank you for that demonstration. That was wonderful. As information technology becomes further integrated into aspects of health care, quality of care and patient safety will greatly benefit. By utilizing data readily available in automated maternal early warning systems, clinicians can objectively assess patient data. Support from an automated maternal fetal early warning system will provide value and long-term benefits to the patient and healthcare organization. These benefits include the potential to avert serious clinical events, improved patient care outcomes, and patient satisfaction. Provision of equitable care is the right for all human beings, and we as the clinicians providing that care should take the necessary steps to reduce the effects of normalizing deviance, curb subjectivity, and utilize automated early warning systems to support care. I thank you for your time today, and I hope that you were able to take something valuable away from our discussion.
Thank you, Alana, for another awesome presentation. Following our webinars, we like to offer a few free resources available for download that relate to our presentation. So we will provide the link in the chat box for that. And as always, you can find it in the webinar section of our website, which is PeriGen.com. And we just want to say thank you. Thank you for everything you guys are doing on the front lines to protect moms and babies during this pandemic and every day. As a first-time mom in 2020, I know the incredible role that you all play for families. So thank you for attending. Hello. I hope you enjoyed our presentation. We're excited to go through some of the Q&A questions. I'm going to go ahead and start us off. I'm Lexi, by the way, and I'm here with KK and Dr. Lana McGolrick. Let's start. We have, so documenting categories is not recommended by the presenter who discussed documentation and litigation because of differences in interpretation. What of the colors that some hospitals are using and integrate when deciding the next steps. These are being piloted in some areas under AWHONN, FHR nomenclature, correct?
Thanks, Lexi. I will take that question. It's a great question. Unfortunately, I did not see the presentation on documentation and litigation, but the literature does support using colors associated with escalation of care. So if you're using an early warning system of any type, there is a color associated with the change in patient status. So our own system has the ability to mimic the categories with a three-tier classification. We also have a 5-tier classification that is close to the pair, and we also have our binary, our original, which is the change in color only to orange. So certainly the colors that are being supported throughout the literature has been incorporated into our product, and you can see that in other early warning systems that are out there right now.
Awesome. There are a couple questions about the discoverability, so I'll read a couple. So you said this data is not put in the EMR, but is it discoverable? And there was another question that says, if it is not part of the EHR, would it be information that is still able to be used should something go to a court of law about the particular labor?
So the one thing that's very unique about Vigilance is that that's correct. It's not included as part of the permanent medical records, so it does not get deposited into your EMR. What it does is it's living on its own server, and the client, so you would have the ability to make that decision on the length of data retention. And for example, you could have it deleted within 24 to 48 hours, or you could have it deleted upon your patient discharge. So it completely disappears. That is something we work with you during the implementation process, and we discuss those options available to you. Data retention does have some great benefits to it because you're able to see data on your patients and any needs for escalation of care or decisions made associated with your patient's worsening condition can be garnered from that information. So we really work with you to make an informed choice on whether or not you choose to retain any of that data.
Awesome. And then there is a couple questions about compatibility. So would this work with Epic? Does this work with Cerner? What systems is this compatible with? Is this compatible with Epic and Obix?
I'm happy to answer that, Lexi. So thank you. Thanks for joining. And yes, the short answer is yes, it is compatible with any system that you have in place. The history of PeriGen is that we do have a full surveillance package. That package has these clinical decision support tools embedded in the system. We realized quite some time ago that it would be advantageous to actually pull those out and package them together so that if you had a system in place, you wouldn't be required to rip and replace to have these wonderful decision support tools. So we can overlay any of the systems that you have in place and interface well with many of them to be able to give you this early warning advantage.
Awesome. And here's a question on education. So it says there is a lot. How do you educate staff about the system without it being overwhelming? How long is the education about the system?
So for the end users, so typically our bedside nurse is included in that target audience. Our end user education program is 120 minutes. It's a blended curriculum. We use a short lecture component at the beginning. It's probably between 30 and 40 minutes in length. And then we do a demonstration of the actual product. And then the staff is actually encouraged to use self-learning modules, which are scenario-based, almost like a patient tracer, and they walk through a patient scenario within the system. So learning how to estimate, the patient care, interventions that may be used, where to click within our single patient view, et cetera, right through the product. And that takes the remainder of the time. We also allow about 10 to 15 minutes at the end for any Q&A, but it's a nice self-paced class once the scenarios are presented, and our instructor is there the entire time, so they're available to answer any questions or concerns that the staff may have while they work through those self-learning modules.
Awesome. Another question is, how would you address providers who are against adopting an early warning system for the OB population?
Well, I think that goes, another great question, but it goes along with anyone that's adverse to adopting anything that might be a change in practice. We encourage all, providers, all disciplines that may be working in the area of women's and children's, so anesthesia, the neos, PDs, anyone that you may have as part of your care team, be involved in the decision making when you're looking at purchasing an early warning system. It does impact everyone's care, and they need to be at the table while you're making this informed choice. So, they're involved from clinical configuration to the education. They attend our classes, right through to their support during go live. So they have all their questions answered also. That seems to be the most successful formula that we have used.
And Kate, I think this one is for you. Are there other auto-MUs?
Are there other auto-MUs? Yeah, maternal early warning systems. I can't speak to every single system out there, so I know that there are MUs embedded in many of your EMRs. Whether or not they're truly automated is a different discussion. Automation means that it doesn't require action by the nurse in order to make their calculation. Most of the systems I've been exposed to, they are dependent on the nurse putting in information or validating vitals for that calculation to be completed. So we are one of the only systems I know of that does that calculation automatically for mom 24/7. I know we are the only system that has MUs for the baby. So that is a big advantage of the PeriGen Vigilance system, is that it is automated for both mom and baby.
They said, is there data to show improved perinatal outcomes in the facilities using your product? That kind of goes along with the other one, asking if there are any published PeriGen studies.
So we do have quite a bit of literature available for you to review that's located on our website under the research tab that talks about the success with the implementation of our tools and where they have impacted in a positive way perinatal outcomes for their units. So I do encourage you to go out to the website and pull those down. It's at PeriGen.com under our research tab. And please reach out if you have any other questions that you'd like to discuss, related to that literature.
Great. And then ask, can you give concrete examples of how bedside staff can implement Vigilance or any early warning system in each assessment?
Okay, so let me see if I understand the question correctly. So our experience with implementing early warning systems, and even my past experience before PeriGen, is that implementing an early warning system, they need to have guidelines on how to use it. So we provide you with a portfolio on the clinical guidelines template for implementation, so that the staff knows when and how and where to use it. The sites that we have worked with, have used with initial assessment, with any reassessment of patient status, and then anytime vital signs may change or you're changing your care plan. So those four good examples of times when the early warning system should be consulted, and that assessment be conducted at the bedside. One caveat with our system is that it's continuously monitoring. We do not have to, nor does the staff have to, set up a time in which to have the system do a calculation because of its continuous monitoring. So at any time, they can go and look at the patient status because there is no lag, there's no calculation, it's calculating the entire time.
Great. And there are a few questions asking if this is available for download. I believe this is. If you look in the top right under downloads, you can pull the slide presentation There are two questions that relate. I'll read both. One says there are definitely positives about this, but I feel like nurses would become complacent and let the computer do all the work for them instead of using their own assessment skills. And there's another one similar saying, how is this accepted by providers, especially those that don't approve protocols because they don't want someone telling them how to practice medicine? It seems they would have a problem with another entity telling them their patients are at risk.
So I think both KK and I could answer that question as we were both at the bedside and we're both nodding. So I'll say my piece and then I'll have KK chime in. So, you know, a couple things with those two questions. One, this is a simple calculator. So it is doing what it's supposed to do. Its job is to set up justification for your decision making at the bedside. It can't see your patient, your maternal fetal dyad. It has no idea what's going on with the actual clinical picture. So instead of, you know, and what I tell the staff is this doesn't remove you as the subject matter expert at the bedside. This actually augments your expertise and your experience that you come with when you're taking care of your patient. So this helps to those 2 o'clock in the morning phone calls. This justifies why I'm phoning to wake up the provider to look at this patient's strip. It also justifies why I need to place internals or why I think somebody needs to, why I need to escalate care at this point. And it also helps to eliminate any other things that may be happening. You know, you don't know what you're looking at. Maybe the strip isn't as clear cut as we'd like it to be, which it never is. So, you know, 85% of the time we are sitting in a category 2 status. And I'd really like to be able to say with some certainty that I have some math behind what I'm doing here. And that way I can phone with some confidence. So that I'll answer that part of the question. I'll let KK jump in with her experience.
Thanks, Alana. You know, and this is a question we do hear quite a bit, you know, and as Alana pointed out, it is a system developed to support you at the bedside. It is called clinical decision support because intuitively that's what it is. You are the clinical expert at the bedside. Again, we can't see the patient. So it is there to help mitigate some of the issues that are common in our current healthcare environments. I know there is variance across hospitals, but overall you see chaotic environments that have a lot of distractors, you know, so that is a huge positive to have that kind of support. We have some facilities who use this as an overview system for the system, and I can tell you that their staffs pretty quickly migrated to being very happy to have that other set of eyes helping them there with support. The other place I have to go with a question like this is, you know, we are all very aware, especially those who are on this call, because you're attending the National AWHONN conference. We're aware of what is happening in the United States with maternal morbidity and mortality. The system that we have in place is getting us the results we get. You know, technology is let to be one of the solutions to help mitigate some of the issues we have here in the United States.
And there's a few questions related to data. So the first one is, would the data be aggregated continuously behind the scenes and alert you to any significant changes, or do you have to trigger it to aggregate and analyze each time? If the latter, how often do you recommend running it? The other data question asks, does this read our data entry in comparison to computer algorithms?
So the system is continuously assessing the data that's coming in from the fetal monitor. There is no need for the nurse to validate it. There is no need for the nurse to send a notification to the system to make to provide an alert at any time. The system will notify if your patient breaches any of the physiological parameters that have been set up in the system prior to implementation. So I think that's the beauty of this, that it's always on and it's always looking at your mom and your baby, not just mom, but also the baby, without any assistance from the nurse. So we don't add to the nurse's workflow. We just provide a very nice singular view of what's going on with the patient overall.
Great. And we have a couple questions related to alarm fatigue. Sorry, they got pushed down further in our queue here. They were both related to just, does the system contribute to alarm fatigue?
So I'm happy to answer that. And again, Alana, let's tag team if I forget something. So again, great question. And I love that conscientiousness about alarm fatigue and noise because it's real and it becomes a real distractor. First and foremost, the Vigilance system does not have audible alarms. They are all visual, purposely, because we wanted to splash some color to get your attention and not add any more noise to your already noisy environment. If there is some alarm fatigue as far as the notifications and the color, we have successfully worked with several of our partners and like tweaked their algorithm or their parameters in their guidelines due to reports that we got out. We really encourage out of the box that you stick pretty close to the parameters we have in place because they're set on guidelines, they're set on industry guidelines or best practices that are out there. However, if over time you see some fatigue in your facility or your system, certainly our team is going to work with you and use your statistics that are coming from your system to help develop tweak those parameters.
Great. And then we have a few questions related to what is the cost and how do you get the additional buy-in needed, as well as the education needed to onboard the system.
Well, I can do the
oh, sorry.
Okay, I could, because I beginning and you could do the end because it's that's the progression there. So your cost is related to your bursts, your birth volume. So it's closely related with that. Truly, honestly, to give you more information about cost, we need to know a lot more about your facility setup, your bed locations, to be able to figure that out. And certainly, if you wanted those specifics, please reach out to either any of us, Dr. McGoldrick or myself, and we're happy to put you in touch with the person that can help give you at least an estimate. And the buy-in starts with the sales process, the pre-sales process, where we come in and we end up speaking to a lot of different groups, and we are happy to. We're happy to be put in a room with, of course, we love being put in the room with our fellow clinicians, but often we advocate that you bring risk management and quality into the room. We advocate that you bring your medical providers into the room. We advocate that you bring in IT and your clinical analysts because they have very valid concerns, questions about the build, about workflow, that we can help explain those and give you a full picture of the product and the support behind it. Elena, I don't know if you have something to add to that.
No, that's great. Yeah, I'm on a delay.
Okay.
Awesome. There are some questions about AI. So what does AI mean to you and how is the Vigilance tool considered AI?
Do you want me to take?
Yeah, that'd be great. And again, I'll chime in.
All right, no, that's a great question. Actually, I was seeing that come up in our Q&A here, and I was hoping that would be one of the ones that was moved to the top. So yes, our so Vigilance and our clinical decision support tools that are with our normal PeriWatch surveillance documentation system are all built on artificial intelligence. So we are lucky enough to have a very astute researcher with our company. So that is Dr. Emily Hamilton. And it is based off of the neural networks, the same that are being used by the Google self-driving cars. We have employed the principles of deep learning for those neural networks. And our algorithm is simply based off of those. So when it continuously assesses the fetal strips that are coming in, it can only get smarter. So we are, like I said, we are very fortunate to have that embedded within our system. So it just keeps getting smarter as it reads more and more strips. So less likely that it would interpret anything incorrectly.
Great. Next one is, does your program have the ability to calculate the acuity of the patient to drive patient-nurse staffing ratios?
So it isn't an acuity tool. What I have done with some of our strategic clients is I've used the reporting function that is available within Vigilance to assist with justification of staffing ratios, with changes to their staff structure, to patient assignments, just based on the information that is provided by Vigilance and how it tracks the occurrence of the early warning system. So anytime the patients are breaching those parameters that have been set by your system, we can tell, how many occurrences are happening within an hour every day of that week. We can go by day, and it really helps for the staff to see that, things that we thought were just in our head, where we have, our baby boom is between 1,500 and say 2,200. Well, it's not really in our head. That's actually when it's happening, or they were having all these blood pressures that were getting out of control, and they wanted to know why. So we started pulling that data. And then the charge nurse actually said, oh my gosh, that's when we start doing all our epidurals. And so you can imagine what's happening there. One, they could be going high because they're working hard in labor, waiting, they're in pain, waiting for their epidurals, and then they're having hypotensive events if they, one didn't react properly to their preload or didn't get enough of a preload, et cetera. So that's just an example of how we've used that information to assist with staffing, but not from an acuity perspective.
Thank you, Alana. I'm getting the notification that we're running out of time here. I'm just going to ask the one last question. Says, I'm sure you could retrieve this data and do some great studies from this across facilities if the data is not destroyed immediately. Can you touch on some of the reporting that you're able to do with Vigilance?
Sure, that's kind of a segue from my last comment here. So we have the ability to look at some really fun data, and for anyone that's interested in the data mining that you can access through Vigilance, there's some really fun things. We can look at notifications to time of review. We can look at, like I used the blood pressure example, to see when Vigilance was firing and notifying the staff that the blood pressures were breaching. We can look at each individual vital sign, and then specifically we can look at what's happening with the fetal heart rate and any of the abnormal uterine activity. I mean, there's some really fun reports that we can pull. And dependent upon what you're looking at, we can, there's no end really to the studies that you can do with the information that's available. But that also leads back to, I think, one of my first answers was on data retention. And that's part of the decision making that we assist you with when we talk about retaining all that information.
Great, thank you. Alana, it looks like we're down to just a few seconds, so I just want to thank everyone for tuning into our presentation. Really appreciate your time.